Hello, everyone. Hello. If you want to grab some wine or some refreshment and take a seat, and we will start in the next few minutes. This will be the best session of the week, especially that Dr. Kreja here. All right. Thank you.
Luego me lo das o se lo das a él y ya está. ¿Y cómo? ¿Cuál es la idea que hablo acá? Ya has visto lo que ha dicho, o sea. Aparte de que era libanés. In a few minutes. Empiezo así como, bueno, de la silla. Yes, I am comfortable. So I should start now or like...
I'll take a white.
Very good.
Camilo, perdón, ¿qué tal? Soledad de Tabaco.
Hola, perdón.
¿Cómo te va?
¿Cómo le va? ¿Yo bien?
All right, everyone, if people can come
Me pidieron
in
unas palabras.
and grab a drink
¿Puedo llegar?
and come in.
Voy a dar la bienvenida.
We actually have a sommelier who's going to give few words about Chilean wine. Although the sommelier, I just realized, Ms. Soledad, is actually from Mendoza. So I know, what's that, Camilo? What's that? Yeah. Okay. All right, thank you everyone for coming. We will start in few minutes. You don't have a drink? I haven't touched it. I'll go get one. I can start. All right, so we will start. Dr. Boza said the sommelier will speak you let me know. So if you wanna come forward and take a seat, but we will start. Dr. Ahmed from all the way from London, Imperial College, and I welcome you. And this session is a special session, is the first session where we are going to talk about practice of obesity treatment, no longer bariatric surgery. And today we're in the beginning of a new chapter, as Dr. Cohen announced. So with that, I invited 5 good friends of mine who are very important key opinion leaders to talk about things that usually we don't talk about. And then I invited members of the industry so we can have them on the stage. As a chair of the corporate council, all I do is ask for money and try to take money from industry. So today, I wanted to value industry and have them speak up and tell us what do they think and how do they see the practice of obesity treatment maturing in the next few years. So let's start. Sinia, right? It's you first.
It's actually Ricardo.
All right, so do you want to introduce?
Sure. Ricardo Cohen is going to be our first speaker. Our president, please come on to the stage. And
he's no longer president.
Ex-president.
We have the Arabic guy now next. He's going to be president for 10 years.
Yeah, I'm a dictator. I'm president. A coup d'etat.
You're good? All right.
Rami, I'm president forever.
And I love it.
Thank you very much, everybody, for being here with us. And Rami asked me to speak on quality and money, mutually exclusive or inclusive. So this is a very interesting question. Disclosures? Well, we have a global healthcare challenge with different views. Patients want better outcomes, they want quality of life, they want a quick recovery. Systems need sustainability, cost control, efficiency, and predictability. Can we achieve both quality and affordability? Well, we have some international evidence that yes, quality pays for itself. Top performers spend less in the Australian and the Dutch health system. So yes, this is the first evidence. The second is, in the US, the North Americans spend most, but they rank less in quality. So North Americans are not top performers. Phil, I'm sorry. Quality drives efficiency. Better outcomes means lower costs. So it's a no-brainer. So proven global models. First, in the Netherlands, bundled payments, single payments for complete episode of care, incentivizing coordination and efficiency. So that's the goal. Second, in the United Kingdom, outcomes framework, where quality and outcomes framework in primary care with performance incentives. So it works. And third, in Australia, quality focus, activity-based funding with quality incentives and transparency and comparisons. So there are benchmarks that need to be followed, and there's comparators. So different systems, same principle, align incentives with outcomes. We have a case study with the Lancet Commission. It's in our field. First, we go from BMI alone by itself to function. So we should redefine the diagnosis of obesity based on function and daily limitations and not BMI only. So this is the framework of the Lancet Commission. Most of you are familiar with the spectrum of preclinical and clinical obesity. But what does this mean? That we need to treat some first. We have different strategies in the same spectrum. This is very well known in medicine. Colonic polyps, for example, they are in the same spectrum of a colonic adenocarcinoma. And the strategies are completely different in the same spectrum of a disease. So an evidence-based approach will target resources where deliver most value, improving outcomes while optimizing costs. So quality and cost alignment through evidence-based prioritization and predictability. So I don't have to treat 2 billion people. I can prioritize those who need most. What payers do today? They invest in complications, ICU, amputations, dialysis, stents. They invest a little bit in clinical obesity and nothing almost in preclinical obesity. Where they should invest? In preclinical obesity with prevention and screening strategies, in clinical obesity, and less in the management of complications. So yes, we had another model that applies to our field, that yes, we can have quality with a wiser investment in health. Well, Rami gave me only 5 minutes, so starting today, I can keep going, but you're limited, so my presentation is getting near the end. We have to choose one pathway. Select high volume condition with clear outcomes, outcomes with quality. Second, define metrics. The case example that I gave to you is I can tell payers and I can tell the patient that we can put obesity into remission, as we can put depression into remission, and we can put diabetes into remission. So we have to have measures of metrics, key metrics. And we need to test a payment model aligning financial incentives to quality. So this is where financial incentives, the health economy meets the outcomes. Better outcomes, no-brainer, leads to financial advantages. So conclusion, quality and cost are complementary when we focus on what truly matters and not scattered plans with confusion within doctors, payers, hospitals. So getting all aligned, and you, industry, getting all aligned with the same goals will save money and improve the quality of our patients. Thank you very much.
Thank you. Let's see what people think about that question. Can you put the question and we can vote? You know, I don't know if the same system. Jaime, do you know if it would be the same system? Is this the same system for voting? Yes, right? Yeah. Let's put the question. This is just kind of, if you want to vote and see your opinion. I think, Ahmed, you wanted to ask a question related to the country you practice, right?
That's right. So, Ricardo, thank you very much for a very nice presentation. And obviously, being from the UK, you know, we have the National Health Service, which you mentioned in one of your slides. Now, one of the issues that we have is we do provide quality for money, but that ends up leading to very long waiting lists. So, if I have a patient coming to me with living with obesity, it'll take between 2.5 to 3 years before they end up with surgery. So, although the concept is a very nice one, but in practice, you know, our health service is not performing as well as you think it might.
Yeah, but that's exactly because it's only stratified by BMI and not the severity of obesity. So if you are a healthcare, public health expert or a policymaker, you should prioritize people who needs first, because payers will only pay for prevention when they're cost effective. And they care about money going out of their pocket first. They don't care about complications long-term, ICUs, etc. So if you prioritize those who need now treatment for their disease at the moment, which is a definition of clinical obesity, you will improve the way money goes to those who need treatment at the present. So I think we need to shift some gears. Some private payers, huge payer in Brazil with 10 million customers, and a huge payer in North America with almost 25 million customers, they understood this, and they undergoing a pilot trial, or I go for those who most need, the sicker, the first. And the others, we can apply the same strategy, but with prevention, like stratifying risk and treating them accordingly.
Thank you. Thank you. We can have one question from the audience. It's just interesting, before they remove the vote, 25%, quarter of this room feel that high quality and money cannot coexist, went down a little bit. Because, you know, it costs more to do all this stuff to ensure quality, hire people. So it's very just interesting, 80 and 20%. We will have, who's next? Go ahead.
Next, I'd like to, is there a question?
Please stay up
Maybe
here.
have a seat, Ricardo.
Yeah.
So should we move on to the next speakers? Can I invite Sanya Majid, please, to come over to the stage? Thank you. And you're going to talk to us on conflict of interest between finances and ethics. Thank you.
Good afternoon, everyone. Thank you for the opportunity. My disclosure. When I look at this topic, I think that the real question is, how do we balance patient care, ethics, and economics? Healthcare is both a mission-driven service and a multi-trillion-dollar industry. And the core tension is patient well-being versus financial sustainability. And I believe this question is extremely relevant today more than ever before, especially in bariatric surgery. Where there are rising costs, there's private equity growth, and then there's AI adoption. Patient care versus profitability. Hospitals prioritize profitable services over community needs, drug pricing, for example, and the medications for obesity and diabetes. We've already seen the impact of this. Insurance and access. Insurance minimizes payouts, providers maximize billing, and the patients are caught between denials and costs. If you extrapolate this to a self-pay model, it's the same thing. Whoever can afford to pay will get the service, so access to care gets impacted. Costly treatments often denied despite medical need. And this would be a connection to, Ahmed, your question to Ricardo Cohen about how do we manage the very long pipeline. And yes, we should stratify based on severity, but then the cost factor would come into play. That's probably one of the reasons why that has not happened in a welfare healthcare system. I mean, you know best, but I think that's probably one of the big factors. Physician-level conflicts. When they are fee-for-service, incentivizes more tests and procedures. Value-based care risks undertreatment, and physician ownership does have an impact on which tests are going to be ordered, what procedures are going to be done, and where they are going to be done. Private equity and corporate ownership, rapidly growing in hospitals, urgent care practices. They are primarily focused on short-term profit and not long-term care. So the whole concept of let's prevent the problem is no longer on the table when private equity is on the table, and there is a rapid growth of that. Linked to staff burnout and obviously higher complication rates, we know when people are exhausted and burnt out, the quality will get affected. AI and technology conflicts. AI is used to cut costs. There's risk of bias. And there's a huge concern about health data being used to monetize. Is it innovation or is it exploitation? Public health versus market pressures. Preventative care is underfunded. I think it echoes what Ricardo mentioned in his slide very well. Most of the payers are paying towards complications and management of complications and not preventing, and obviously population health suffers long-term because of that. So the core ethical conflict, medicine, do no harm, and equity, where finance is all about maximizing returns. So are patients customers or people with a right to care? And that's a question that I would really want all of you guys to really think about that. We use the word customer service in healthcare. Are they really customers? Why it matters. So there are studies, and Rami, thank you for bringing this study to my attention, that has attempted to dig deeper into this question. I don't want to single any one industry. It just so happens that this is the industry that they chose to publish on. But the key point here is that 458 studies met that inclusion criteria, out of which 76% had a declaration statement, this is declaration of conflict of interest, versus the 23.6% where the declaration was not present. Within the 76% where the declaration was submitted, 82% declared no funding, but 63% of that 82% had funding given. And the way this was proven was because of the Open Payment Sunshine Act in the US from 2010. And obviously this applies to American authors and American systems, but I think we have a lot to learn from this globally. High rates of undeclared payments was one of the conclusions these authors reached, and 20% of studies with a conflict of interest declared it in a conflict of interest statement. So only 20% of studies even declared that, and 18% of authors who received payments declared it. And one other observation was when the amount was low, which was classified as under 10,000 US dollars, it was not declared. And the higher amounts, greater than $100,000, were declared. And there was, the authors concluded that it did impact their support towards at least that particular device. Reality. Finance versus ethics battle will persist. I don't think this is going to ever go away. Financial drivers are deeply embedded. Conflicts cannot be eliminated entirely. The best approach to this problem would be to acknowledge, to monitor, and to minimize harm. Transparency is key. I do suggest that we should start asking people to declare the amount of dollars or whatever currency that they are being paid in, along with just listing who their, in their disclosure, who their industry partnerships are. They should also further add on the amount of dollars or money that they are receiving. Policy reforms like drug pricing, insurance accountability, align incentives towards outcomes and not volume. Thank you.
Thank you. Thank you very much. Can we put the, again, simple questions here? Paulina, come up if you want. We'll put the poll. So conflict of interest, finances and ethics. Great talk. You actually expanded much more than I thought, so thank you very much. Jaime, you're going to be, does everyone know that Jaime is going to be the next president? So as our new leader, and as someone who works with me and know very influential with industry, in 1 minute, now we have a lot of industry representatives. How do you personally manage? You work with everyone. What is your advice here? How do you personally manage? You're going to be the president. Everyone is looking up to you. We will trust you to make the right decision. This is why I put this together so we can ask these difficult questions. How would you personally manage, Dr. Ponce, your influence and your own payment and how you make decisions that are fair?
So I think, first of all, I think it's important to distinguish that industry needs us so they can develop what we need, the tools and the instruments and the devices that we need to take care of patients. But we also need industry to improve our ability to do what we do. So we need to see it in that perspective, in a collaboration perspective. The conflict of interest that you're talking about is when we get paid for consulting or education or proctoring or even having stocks on a company. That's very different, and that has to be part of our financial disclosures. You have to always step aside when there is a decision making around that kind of industry there. But I do think that us without the industry and industry without us is not going to work. We both need each other to improve and keep improving what we do.
Senia, there is 19% that said no. What do you think? 1 in 5 people in this room feel that if you get paid, you cannot be 100% ethical. I know Ahmed wanted to ask, but I'm itching to ask that question. This is my favorite topic today because we put that first slide, conflict of interest, and we go through it, and Paulina is shaking her head because she does all our data. I think the most commonly used word this week was data, and some other words at the bars that I was not involved. So say 18% feel they don't exist. What would you tell people? Is that true? You know?
The challenge behind this topic is that really boils down to the individual. What is your definition of ethics and what are you comfortable with? So kind of what Jaime was saying, that yes, industry and the clinical partners need each other, no question about it. But who will let that influence and who will not is then left on that particular individual's discretion. And that is why this is such a difficult question to answer. And I understand, and I'm glad we don't see 100% because then that would not be, everybody is not really thinking about the question. So when you're boiling down to the individual ethic comfort level, there will always be, I think, a conflict of interest and a difficult thing to maneuver, which is why I go back to we've got to have practices in place that monitor and make it difficult. So that open payment, for example, is a great tool that is public information. And physicians can actually challenge that, and others can use that to make the decision of whether they're going to take that recommendation or not.
Thank you.
I think we have a question from the front. Thanks.
Claudio, can you say your name and where you
Yeah, of course. Hi, I'm Claudio Canales. I'm a past president of the Chilean Society. I like this topic very much because I wanted to ask you, in Chile, I had to do the work in the Ministry of Health, and they were looking exact that none of us has conflict of interest, and it happened to me because COVID, I was president during COVID and stuff, so I reunion the years that I was not paid for a talk or whatever, so that happens by chance. But my question is, how do you manage when in the ASMBS or in your country societies, they need someone to do a protocol or to do something that has to do, with the scientific evidence, to choose them and to be part of the team and help the Ministry of Health or government or whatever? That's my question.
I just want to understand your question. How ASMBS,
Is it important, an example, in the ASMBS, if the government tells you to resolve some scientific issue, that the people that you sent in that committee has no conflict of interest, and how you do it, and how you handle it, basically?
great. So the ASMBS leadership comprises of a board of directors, and we have some past presidents right here, so keep me honest. And then they elect the representative to, let's say, the American Medical Association, which is our big organization, inclusive of surgeons and other physicians, that then have seats based on the size of the different societies. So ASMBS, based on their number of members, have a particular a seat on the AMA, which is the American Medical Association, then corresponds with the government. So there's a whole process in place based on how many members you are serving. Did that answer your question?
No, but you take care that these people that has this path doesn't
Right.
have conflict of interest.
Correct. So the board responsibility is to make sure that the person who's representing is truly representing in the best interest. And that happens because it's not one person's decision, it's an entire board's decision.
Great. Thank you so much for your talk.
Stay up here, Sinead.
You have a seat next to Jaime. Next up, we're going to have Phil Shower talking on innovation, money, and power. Is there a right balance? Thank you, Phil.
We worked very hard on your computer, so you can do it this time.
Okay, thank you, Rami. Okay, all right, I think this talk follows nicely Sinead's talk. While there can be conflict between a surgeon, investigator, and industry, we can also do it right. And when we do it right, that's power, because that can actually change the field in a very positive way. And I want to talk to you about that. But first, my disclosures. And Sania, I promise next time I'm going to show you the open source and the actual dollars. Some of these I get zero from, but I think that's actually a good idea going forward. So innovation is important. It's the lifeblood to our field. I think all of you know that. It comes in many shapes and sizes. It can be a new procedure, a new device, or it can be an application, a new application of an old procedure, like gastric bypass for obesity or gastric bypass for a new indication, diabetes. And I will argue that collaboration with industry is critical to advance our field of metabolic surgery. A lot of research in the United States, biomedical research, is acquired through funding from the government, the National Institute of Health. But often the NIH is not necessarily interested in clinical trial work, particularly in our field. And so we have to get funding to get this type of research and innovation done, and it's critical. So you can't have innovation unless you have money, but if you can get innovation, you can achieve power, that is power to advance the field for improving patient care. Now, luckily, and I'm so happy to see it, if so, we have really a very generous support from industry. Here's some of our industry leaders, and it's nice to see it's not all medical device now. We're actually beginning to see pharmaceutical support for IFSO, and it's not just to support this meeting, but a lot of these companies have opportunities to receive grant requests if you have a good idea to review and possibly fund. These are investigator-initiated studies, and there's often a big firewall between industry and that investigator. In other words, the investigator puts forth a protocol, designs it, and industry decides whether they fund it or not, but they're not going to impose on the trial or the results or the evaluation. And here's a couple good examples from Johnson & Johnson, Ethicon, and Medtronic. You can go to their portals and understand the process to submit an idea, a full grant. It's peer-reviewed by their advisory boards, and you get an answer. They will fund some things. Sometimes they'll request you to revise it, but this is an opportunity for you investigators out there, if you're not familiar. In addition, now we're seeing pharmaceutical organizations like Novo and Lilly and others beginning to entertain studies that relate to not only GLP-1s, but also metabolic surgery as well. I want to show you a few examples. One of the best examples I'm most familiar with is a trial that I was involved with, the Stampede trial. These randomized controlled trials comparing surgery to medical treatment are very expensive. They're difficult to do. This study cost more than $7 million, and it couldn't have been done. I don't think the NIH would have supported this. And this was largely funded through industry, Ethicon, and it has had an impact on our field. Now, following this, we wanted to collect more data and longer follow-up. So we went back to industry to get bridge funding to give us time to submit an NIH grant, and Medtronic stepped up with Ethicon to provide bridge funding to develop the Alliance of Randomized Controlled Trials for Metabolic Surgery, which gave us time to bring 3 other centers, University of Washington, David Cummings, University of Pittsburgh, Anita Korkelis, and the Boston group, headed by Mary Elizabeth Patty. And then we were able to successfully get an NIH grant to the amount of $10 million to actually do a much larger trial. This is the largest trial and longest follow-up comparing metabolic surgery with medical therapy for type 2 diabetes. And it was very, very supportive of metabolic surgery being superior to medical treatment alone. So here we used industry to help get started. We eventually got NIH funding, and this helped, or has helped, or will help move the field forward. Let me show you quickly some other examples. This is a very well-known study. Saeed Ikramudin, University of Minnesota, was the lead investigator. This was funded entirely by Medtronic, multi-million-dollar study, which also showed very favorable results for metabolic surgery compared to medical treatment of type 2 diabetes. Here's a study by our former president, Ricardo Cohen, looking at metabolic surgery for the treatment of chronic kidney disease. This was funded by Johnson & Johnson of Brazil. And yet another study, Carlos Chavan, looking at metabolic surgery for hypertension. And this was funded by Medtronic and Ethicon. And again, these types of studies probably would not get done without that industry support. If you look at the top 50 publications in our field based on the number of citations, many of these were funded by industry. And many of these appeared in the top high-ranked medical journals and went through all of the intensive peer review that is required. So high-quality research can be done with industry support. In fact, if you look at the top 5 cited papers in the history of metabolic surgery, I think all of them. I'm not sure about the SOS. I don't think it was originally funded by industry, but I think some follow-up funding was acquired to continue that long-term follow-up out to 20 years. Okay, I'm wrapping it up. Okay, and I'll just say briefly, in addition to research, industry has funded education, which is an entirely important additional topic that we don't have time to go into. But I'm just saying that these collaborations, while there can be conflict of interest, they can result in tremendous benefit to our field in terms of new research, moving the field forward, and educating our surgeons as well as physicians about the benefits of metabolic surgery. So in conclusion, our colleagues in industry have, and hopefully will in the future, continue to support further research and education to advance metabolic surgery. Thank you very much.
Incredible, Phil. Thank you so much. Paulina, can you go up here, please? Can you up to the moderator? And I want to ask you, as you walk, Paulina, you and Ralph did the most recent couple of randomized clinical trial. Can you and Phil both comment on how do you, because I want to create a little bit of conflict. We all love each other, and there's wine. It doesn't look good. I want a little bit of spice. How do you guys decide? So when you do these randomized clinical trials, they're very costly. You work with industry, and you're very, very influential. When you say something, people follow you. How do you decide, Paulina, when you do these randomized clinical trials? Do you call industry? Can you help people in the room understand what goes in your process, in your head? And then I want Phil to say if he agrees or disagrees with you.
Sure.
Well,
Actually, to be honest, I've never been industry funded in any of my RCTs, and I have 8 multi-center ones on either metabolic bariatric surgery or acute appendicitis. So it really is the majority of the funding in the Nordic countries actually is foundation based. But this is actually something that I think it depends on the topic. Like if you want to have an investigator-orientated trial, and if the question that we're doing, like for example, this is not MBS, this is appendicitis, I did not want any antibiotic company to sponsor it because I want it to be from truly an investigator independent trial. But for this, I would see, because it's so insanely hard to get research funding. So I would say that we really need our industry partners to do this. And I will be calling everybody next week.
So she's saying that where she's from, she's doing this with the foundation. Phil, you're in the US. Can you just educate us a little bit about the difference and if you agree with her?
Yeah, well, if you can get funding, God love you, however you get it, whether it is through, foundations, through government work, or through industry. And the point I'm making is that there are mechanisms to avoid conflict of interest. For example, all of those landmark papers I discussed with you, there wasn't a single mention about a branded stapler, energy device. It's very generic. And I don't think industry's intent was to sell their product. What they wanted to see was, what is the real impact of this surgery? And perhaps they may benefit if there is positive impact, but there's also the risk that these studies may not have been so successful. And those are the risks they have to take when they consider, investing. But so I think there's a lot of different opportunities to obtain research funding, and there's ethical standards to achieve it no matter where you're getting the funding.
Just quickly comment, because I think if it's the funders actually don't have any role in the study design or how to interpret the results, I think that's absolutely clear that it is still pure scientific data.
Thank you for making both of you that comment, because a lot of the younger people, when they look, they see Ethicon, they see Medtronic, and when you were in Cleveland, you worked a lot with Ethicon. They get confused, right? So it is your job, Phil. It is your job, correct? Your job is to make sure that you don't talk to Ethicon, Medtronic, Boston, anyone while you are doing this, correct?
That's correct. That's
Exactly.
quintessentially what an investigator-initiated study is.
Right.
It's the investigator designs the study, the hypothesis, the protocol, the evaluation. Industry steps away. Now, industry can directly sponsor a study, and that's where they have control, and that's very different. But what I'm talking about are investigator-initiated studies where there's a clearly arm's length distance between the investigator and the funding source.
Great, thank you. While we switch, can you, who's the next speaker? And Ahmed has Marina, do you want to go up while Dr. Ahmed? Go ahead, Ahmed.
Phil, I'm going to just be a devil's advocate here, and I need to push you a little bit more on this, because,
Please.
I mean, to a learned audience we have here, and to the medical journals, we all understand, independence. However, when the media sees that a study's been sponsored by let's say, a statement company, or Joe Public sees that there's research is sponsored by a statement company, they will automatically think that there's bias. So that's always going to be an issue. However independent we try and make it look, but there's always going to be this stigma associated with research sponsored by industry.
Yeah, well, when you submit your work to a journal, a high-impact journal, you go through intense scrutiny, particularly, the top journals. Let me tell you, those reviewers are not necessarily friendly, and they address all of those issues. Where did this idea come from? Who wrote the paper? Was industry involved in the interpretation of the results? And so I think the scrutiny is pretty high, particularly in these extremely high-impact journals.
I can only imagine if Paulina is a reviewer. Just think about it. Jaime, you do a randomized clinical trial and Paulina is a reviewer, you just might as well just walk away. What do you
He's
think?
going to have an excellent
No,
peer
I
review.
mean, actually, that's good. I mean, it's good to have on that side somebody that criticizes your trial as much as he can, so he can be vetted.
Yeah.
But look at this, Jaime. Again, 20%. If someone just has the guts who did the 20% that there's no balance, come up to the microphone. It's fun. We're having wine. We want to have a little bit of challenge. Come up. Frank,
I think
is that you?
the catch, Rami, is this thing about unrestricted
You?
grants.
Oh, of course, Reza.
And that's the same thing as the NIH, should be treated almost equivalent to an NIH grant. So when they give you that grant, you're just going to have to separate it. Thank you very much. And then we're going to do the trial, never talk to them, and trial is published, and then they can get upset or not, but that's the problem.
So now the 20%, as expected, is Reza. Get some spice,
No,
Reza.
the reason I'm coming to the microphone is to support what Phil's saying, because if you look at the growth of the industry, if what he wrote with the Stampede helped growth of the industry as the industry of bariatric surgery, the science of bariatric surgery, the usage of bariatric surgery, if what he did, that is completely independent of which company. Was it Medtronic or was it Ethicon? As long as he clearly declared it and very in detail declared that there has been no meetings, apart from a basic support, there has been no contact whatsoever because that Stampede trial with the citations grew bariatric surgery.
I could not agree more. I think it's a win-win
I thought you came in to
situation.
fight.
Just
No.
to back up.
Okay, I think
Could not agree more.
we need
All
to
right, let's move. Yeah.
move on. So I'd like to, Phil, if you have a seat on the panel, and I'd like to invite Marina Kirian to talk on private equity to save or destroy USA healthcare. Thank you.
Guys, I'm going to stick to the 5 minutes that we were asked to give a talk to, I think at least. So I have been approached in the past by private equity to you all that are not in the US. Basically, they come in and buy your practice. And so you get a payout, and the disclosures don't matter because this is non-CME, so I'm moving on. But I asked AI to give us the best version of private equity, and here it is. They do a leveraged buyout to purchase your business. It first started for us with ophthalmology and dermatology, but they're also approaching now large general surgery practices and definitely some bariatric practices. And the idea is that they will take on the debt and then start introducing strategies so they can increase their own profitability, and then ultimately, usually in 5 to 8 years, they look to sell the business. So there's some issues with all of that, so they would be critics, and I think Sinai would be one of them who would say, this is going to be a focus on profit and therefore turning healthcare into a commodity, and it can definitely jeopardize patient care. And this is something that different people have published on, including this is from an article in the Journal of Ethics. The aggressive acquisition and consolidation of physician practices, which does also happen, can also lead to reduced competition and therefore affect the pricing of what we do, because there's no more competition. The debt that's there that the companies are acquiring can create a lot of financial instability and even bankruptcy risk for the target firm. And there are also these inherent conflicts between maximizing the profit for the investor, but still, as Sanaya talked about, quality care, and actually, not Sanaya, Ricardo talked about quality care and how much that costs, and that you can do both. But the concern is that in the healthcare sector that if you do that, you end up cutting costs. And you guys can imagine, sometimes I'm in the OR and I'm like, why do I have this drape? What is this like flimsy little drape? Where did it come from? And of course the answer is it's cheaper. That's why we have it. So the cons of going there, again, to a private equity is really implementing the rapid cost reductions that they want to boost the profits to their investors, generate these returns, and that could involve either reducing the staff or cutting out other expenses within your practice. So, but what are the trends in the US? It's really concierge medicine. So many of our internists now only do concierge. They take like anywhere from $350 a month to some do that for the year, but most are doing a monthly fee. And then they are available to the patient at any time. There's in New York certainly a couple of private emergency rooms where you just show up. They do run your insurance, but you pay up front for everything. And there are people willing to do that rather than wait in the hospital. And most of the hospitals in New York City area are actually private, non-for-profit, but there's a few that are city hospitals, public hospitals, and the wait there is even more than it is at the private hospitals. But we already, if you look at that, in the US particularly, have a great disparity in care, depending on which neighborhood you're from, where, you know, there's so much disparity in healthcare that I think is really even more in the US than it is worldwide. And we already have inadequate care. Somebody at this meeting went ahead and said, oh, it was probably Ralph Peterly, who else? He said that, our US healthcare is actually sadly down in the lower part of delivering good and quality care. But who are the winners in this situation? It's the owners. If you are like more of the senior partners, if you imagine, then you have less stress on your practice. So they will be they'll be the ones that will be getting the debt resolved. They'll look at their the price that they'll get for their practice. But the people who work for them, I'll get to those in a second. And then the winners are obviously the investors who are looking to make money off the practice. The losers are the non-owners, the people that are employed, and the patients, because with cost cutting, it's going to affect their access to certain parts of your practice, and also outcomes will be affected. So in conclusion, for private equity, it's short-term but significant monetary gain for owners. Long-term, I don't think it's a financially stable situation for all of the physicians that might be in a practice, and I do think that cost cutting will negatively impact our health outcomes. This is already happening. You have senior surgeons in these practices that are bought out, and then they end up getting let go and replaced with junior surgeons. And I've seen that in a couple of practices, no names yet.
Thank
I'm
you,
done.
Marina.
Great, thank you.
Can we put the slide for voting? So what would you vote, Marina? I put emojis here. It took me forever to figure it out. So is this gonna destroy the US healthcare system eventually? And I will invite Paul Enochs to maybe comment, because Paul worked with private equity. He's one of the bad guys. We worked with private equity.
I would vote that it's going to destroy, because now physicians are just, it's the same as joining a hospital in a way. We're just commodity items that can be replaced. And no more do they think that the surgeon is drawing the patient, except for those with 150,000 Instagram followers, right? That's not me.
Let's explain, because a lot of people here are not from the US. This is if so.
Yeah.
So basically what they do, private practice, they would come, they would just look at what's called EBITDA, which is your income before taxes, and they give you a multiplier, and they just give you in one lump sum payment, millions of dollars sometime, and then you have to sign a bunch of things to work with them. What Marina is saying, this will destroy surgery, because now we're working for bankers. So we're not working for hospitals, not that hospitals are angels, but bankers are corporate. So what Marina is saying, eventually doctors will not do well because they're managed by bankers who are only looking at ROI, which is return on investment. Paul Enochs, one of the busiest bariatric surgeons in the US, was so good that private equity did approach him. So Paul, can you tell us maybe what do you see the light in private equity?
Well, I think Marina actually was accurate in what she just said a few seconds ago, in that private equity is a lot like hospitals, in the sense that, unfortunately, a lot of physicians in the US right now are faced with two choices. Because of what's going on with GLP-1s, and even before that, eventually you can't just stay on your own. The private practice world in America is starting to crumble because of just all the pressures we have. And so you have to align with somebody. Now, the question is do you align with the hospital or do you align with private equity? And they're acting in the same role. The difference is, at least as a private surgeon, if you sell out to the hospital, you're basically getting pennies on your dollar, if anything. They basically just buy your equipment, and that's it. The potential is there that if you sell to private equity, instead you can get value for all the time, effort, work you put into building your practice, which a hospital will give you no value for.
Thank you, Paul. Sachin Kukreja, another very successful private practice. Do you want to stand up and say where you practice, Sachin?
Hi, Sachin Kukreja from Dallas, Texas. I have a bit of a comment and a question for the panel and maybe for other people in the room. So there's been this greater push for transparency in medicine in the United States, right? Hospitals now have to declare their charges. You come get a surgery at my ambulatory surgery center where I'm invested. You have to sign off on that. We have CMS publishing open payments, which is patients don't really know how to find it, but it's out there. Patients tell me how much I got paid to do a surgery because they review the EOB, right? So, and I think these questions that were asked were all yes, no, black, white, binary. And the truth is probably somewhere in between as to whether we can really practice medicine ethically if we are paid by industry. The problem I have is I think that it's actually probably much cleaner with big companies, right? Big companies, they have many people representing them throughout the surgical world. It's in the smaller companies. We all know surgeons that seem to put mesh on every hiatus. They seem to wrap every anastomosis with a biologic. And when you actually look, they are investors, or they do receive money. So my question is, should we be required to tell our patients ourselves before we do a surgery, or should it be available to them on the consent form? Here's how much money I got from company A, B, and C last year, and we are using products from B and C during your surgery. Should that be a requirement? And if it were encouraged, who here who receives money would be willing to do that?
Wow, that's Jaime. Senia, that's for you and Marina. You do a lot of out of network, but that's we're not going to discuss this at If So platform. But it's very interesting. Does anyone here or in the audience? We're running behind, but I think this is pretty good. I'm going to keep it. And Dr. Ko, you can start coming up here. Does anyone feel we should disclose to the patient how much money we're making out of their surgery? I would love to disclose Medicaid because I get $700 out of the surgery and 90 days. But also I do $6,000 for private pay. So anyone, Jaime? I'm sorry, Senia, I didn't see you. Why don't you go first, Senia? I don't want to be rude.
I think this is a brilliant question, and ultimately in an ideal world, yes, we should be able to disclose that I think you should, in an ideal world. The question is, who receives that information and how they're going to interpret it. So our patient population is so broad and so diverse, we should not be treating some patients with more information than others, right? We should be treating all patients the same way. So my question, Sachin, to you is that in your patient population, do you have the confidence that they will focus on what really matters, like in our case, bariatric surgery, or they'll get distracted by that piece of information which makes you feel good, but ultimately might not make a difference or potentially complicate the decision for the patient?
I think it depends
You
on
have 20 seconds because we need
it depends
industry
on
up.
when that information is given. I've never had a patient walk away from the surgery center because they walk in to have surgery and have to sign that, oh, he's invested here, right? But if they know that before they ever see you at first consult or at first consult, I could see that pushing a patient away, or at least introducing question.
All right.
It's
So-
just how you present the information to the patient. The patient loves you and they want to stay with you.
So yes
I
or
trust
no?
on you.
Do you disclose or you don't disclose? We need to, yes or no, Jaime? Do you think a time should come where you disclose to the patient how much you get paid?
I think time will come that the government will ask us to disclose, yeah.
Phil?
Like open payment.
You're in academic. You probably don't know because they do RVU system.
Well,
So
but it's a little more complicated, particularly if you're based on a salary. But even the private world, if insurance X pays more than insurance Y, and are you going to tell the different reimbursement rates? It's very complicated. Should we publish all of our income? Should we let the whole world know about our income tax return? Maybe that's going a little too far. I don't know.
All right, let's. I'm going to cut it off. This is great. We need to do that in Toronto, definitely. Dr. Crow, can you, before you talk, just tell a little bit, 20 seconds, why I chose you and the journey where you were and where you are now to give a context of this talk. I think it's very important.
Yeah, I will, and I actually put it in my slides too. So, Rami, you gave me a really provocative topic here, and I don't think it's really the right title. It's not really a way out. We're surgeons taking care of patients. It's a privilege to do that, and I'm immensely grateful to have done that and continue to do that. And a lot of these topics resonate on both sides. There aren't different sides to taking care of patients. We're all in this to take care of patients at the end. So for the kind of younger people in the back of the room, how did I in particular get here? It was never by design necessarily, but I trained at an institution that was pretty innovative. I ran into a couple people along the way that served as mentors, a couple of them sitting in the room here today, that really significantly impacted my career and taught me about different technologies where we were looking for solutions that didn't exist. Some of these worked, some of these didn't, but we were kind of on the forefront of making decisions way back then. We knew there was a problem. We didn't have the instruments to get there. But as an academic and clinical surgeon, we also published along the way. We were quite honest. We thought, well, these are great opportunities, but maybe we're not doing better for our patients. And that's a very critical piece as an academic surgeon to keep kind of digging into this a little bit more. Other technologies came, so maybe some of those initial applications weren't where they needed to be, in particular maybe notes procedures, kind of circa 2014 when the first palm procedure was done at Cleveland Clinic. But it was a great opportunity to take these tools and rebuild them in a different way. Maybe for treating achalasia to start, but other diseases like gastroparesis, which also didn't have good answers necessarily. And then critically important to make sure that we're publishing this in high impact journals to impact our fields. And that was really very meaningful to me. New technologies, techniques, publications really kind of helped the basis of my academic career in Cleveland and Ohio and in North America. But then I had an opportunity to kind of take this internationally, not just build clinical service lines that didn't exist in a country before, like Abu Dhabi and the UAE, but also impact segments of the population that weren't getting this type of care before. And that was really powerful to me. So it's not about promotion or way out, but impact. And I'd like to kind of flip the question a little bit. Leaving the OR doesn't mean that you're leaving medicine. We're just scaling in different ways. Many surgeons, probably the majority of the people in this room, have collaborated with industry in some way because fundamentally that's why we became surgeons. We're innovative by nature, we're problem solvers. And the opportunity to take decades of insight and then channel that into an impact that helps millions of patients is really powerful. So currently I'm a chief medical officer at Medtronic in the core surgical innovation. And in our company, the needs of different regions are wildly disparate. And you see that in a meeting like IFSO. For us, we think about robotics and digital surgery and laparoscopy, but also open surgery. And what does that mean in different regions of the world? And that's really powerful across the broad spectrum of subspecialties. And the roles are vast. And not nearly a year on the job, I'm still uncovering what that all means, but it's really powerful. And the number that really impacts me, and one of the reasons why I joined, was that for every second of every hour of every day, our products impact 2 patients. And that's really powerful. As an individual surgeon and endoscopist, maybe I treat 20, 30,000 patients over the course of my career, but now it's millions of patients. So why is it really important to make sure that we have surgeons in industry? Well, we have clinical credibility. We have real-world context, what works, what doesn't. If it's 2 o'clock in the morning, you need a solution, like you've been there, you know how to fix those things. And how do we translate this between engineers and the business acumen and the operating room? Innovations can't just be elegant, they've got to be relevant, and that clinical insight is really important. And I think having clinicians in executive leadership role build trust in the devices and technologies we introduce. And that resonates with the entire specialty of metabolic and bariatric surgery. We're trying to develop less invasive care. We have to make sure we do this in a cost conscious way to bring new innovations that are meaningful. And it can't be just in your city, your country. It's got to be around the world. And that means there's thousands of hospitals and millions of patients we're impacting. Additionally, we help shape that evidence. We've heard it already from Phil. Industry is uniquely resourced to generate the data that influences practice and guidelines. And that collaboration is local, national, and international. So what are the unique perspectives of a practicing surgeon? We see the unmet needs firsthand, and we understand the balance between outcome, safety, and performance. And sometimes those leadership skills are honed in the operating room. And that actually resonates in industry as well. So Rami, industry is not an escape hatch. It's not an out. Done well, it's an extension of what we're all doing already. We're treating individual patients as surgeons, but now we're shaping technology in industry that treats populations. New intellectual challenges, regulatory, economics, global health trends, we touched on those already. And industry and academia are better together. Academia thrives on discovery, training, and evidence, and industry helps bring this to scale with speed and execution. So in the end, really, we both share the ultimate goal, and that's better, safer care for our patients. So really, I know you chose this topic to be provocative, but crossing into industry isn't about stepping away. Surgeons can and should shape the tools, systems, and solutions that define the future. And industry is influencing surgery at a different scale, influencing design, policy, economics, and access for our patients. Thank you.
I think there's no reason to put any vote. I think you nailed it, Dr. Crow. I could not have wished for an answer like this. In the interest of time, so we can allow our industry people to come up. If you want to take a seat here. Jaime, how do you like to do? Do you want to stand? Do you want to do it from here with the remote control? How would you like to do that? Do you want me to go up and advance the slides for you? I can do that. You good? Yeah. So can we invite, as Dr. Pan said, can we invite the industry members to come up? We ran behind, but I allowed it because this was great. As Dr. Ponce gets settled, please have a seat over there. Ahmed, can you not have the, like...
Yeah.
The,
So this
like,
is
straight?
this is an interesting topic that you gave me: the rise and fall of our beloved medical devices, lessons learned. And so my conflict of interest, none of those have any conflict of my presentation here. So I'm going to use just as a case study the lap band. So everybody knows lap band, raise and fall, very easy. Lap band got approved in 2001 by the FDA. That was based on an FDA clinical trial at 3 years, 36% excess weight loss. And it also had a competitor realized band that got approved in 2007, also with 41% excess weight loss at 3 years. There was no randomized clinical trial. There was nothing else besides a multi-center prospective observation study. So 3 years follow-up. So what happened with this device that got approved in 2001 and start rising up to a very prominent number of sales, you know? So I think the promise here was the sales. You know, there was a promise of minimally invasive. There was a promise of reversibility, of safety. There was a promise of low complication. And that's what we all believe. We all believe that that was going to be a surgery that was very accessible, and patients and surgeons adopted the technique because it was new thing, it was cool to do it, and it was adopted by everybody else. Now, first major mistake that I think happened is that everybody overstated the results of the lap band and start comparing it to the gastric bypass. And I'm just going to show you things that were not quite right, you know. It became synonymous with bariatric innovation in the early 2000s, but this is the graphics. This is a graphic from 2004 published in Australia. And look at that. Gastric band, gastric sleeve, and gastric bypass, even though the sleeve and the bypass had better weight loss at 1 and 2 years, at 5 years, they were going to be equivalent. We all know that that is not true, but this is the promise that we will be given, and I think that was wrong, the overstating that promise. But regardless of that, in the first 5 years of the approval, there was a 10-fold increase in cases, and it was an aggressive direct-to-consumer marketing. There were centers built entirely around the lap band, and all was very appealing to patients because it was low risk, to self-pay models, You can start seeing all the advertisements that were done at that time. You remember in United States, the lion, the patients showing their success. In centers like 1-800-GET-THING in California, Texas, it was built a whole entire aggressive money maker centers around the lab ban. That's a reality. And look at the numbers, it's staggering. That actually helps the total number of bariatric surgeries in the United States grow significantly at that time. Look at those numbers, they grow exponentially. Now, there were major lessons that industry could learn out of this experiment. There were major loss of opportunities. If you think about it, J&J, Johnson & Johnson, Ethicon had the opportunity to buy the lab ban from Inamed in 2001 after the approval. Inamed said, oh, I'm going to sell it to you for $400 million. J&J said, that's too expensive. So they went in and bought the Swedish bans. Now, if you think about it, the loss of opportunity is this one. Inamed was selling in 5 years, $400 million. Inamed was acquired by Allergan for $3.2 billion in 2006. And if you were to buy stocks from Inamed at that time in 2001, when the lab ban got approved, you would have got 800% out of income. They split the stocks, you make a lot of money out of that. I wish I would have done that. I just stopped a little bit before that. But the other thing, the other red mark that I see here is the real world outcomes failed to match the initial promise. A lot of variability in the results, as these are Bessler's outcome data on where the results of the lab ban patients were. There a lot of variability, a lot of high rate of band removals. So the explant rates were increasing, and then the band complications were more expensive. This is data from Medicare showing that the complications were expensive. Negative media stories about how the device was plummeted globally. It was no longer viable because of all the complications, all the problems. And then you have a nice bell-shaped curve. Went up and then went down. And so that's the experiment of the lab ban. So key lessons from this innovation to obsolescence is short-term data was not matched to long-term outcomes. Aggressive marketing without clinical maturity can backfire you. Real-world registry data was critical. Devices are not one size fits all. And I do think that we need to learn from these past cycles in the future. There's going to be a lot of devices that are going to come in the future, and that we just need to do innovation with clinical humility. I think this is very important. You need to be humble and be not overstating the things when they come up into our hands. The lab ban actually wasn't a failure. It was just an overstating of the system. The lab ban actually, if I give you a device right now that is going to give you 15%, 20% weight loss in a outpatient fashion, you probably will look at it as an ideal thing to embrace. So we need to recognize the failures before and not start making overstating outcomes. This is the ASMBS in San Antonio. I just wanted to promote that, and thank you very much.
Thank you, Jaime. We ran behind, but I think we're still okay. But sorry that the chairs are not meant to be like two people compartmentalized. So feel free to turn your chair if you want to, or sit back here. But I will. This is what I wanted as we reshape the corporate council to allow the generous industry partners who are coming together to go on stage and voice their opinion and whatever controversy. We'll try to go quicker than I thought, but please introduce yourself as we start. Maybe here we go. Just your name and what company and what's your role, please?
Yeah, good afternoon. My name is Tracy Sims. I'm a member of the Cardio-Metabolic Health Corporate Affairs team at Eli Lilly and Company. Happy to be visiting from Indianapolis, Indiana. My role is combined health policy, and I'm a real-world evidence research scientist. Glad to be here.
Thank you so much for being here. Gina?
Gina Baldo. I'm with Medtronic in the U.S. marketing group, and I've been working in the metabolic space for about 30 years.
Hello, good afternoon. This is Andres Gravenhorst. I'm representing Johnson & Johnson. I'm the lead for surgery in Latam, based out of Mexico.
Good evening, everyone. I'm Brian Duncan. I'm the Chief Medical Officer for Boston Scientific's Endoscopy Division.
Thank you. So I'm going to start, really thank you, actually. I know GT Metabolic had someone, but had to run to the airport. And Intuitive, I'm not sure where they are, but I'm going to start with you, Gina, so we can go, because I know you the most, I can kind of push you a little bit. When I was a resident, it was only Medtronic and Ethicon, not even Intuitive. Earlier today, we heard Ricardo Cohen changing the name International Federation for Surgery for Obesity and Other Treatment. So all of a sudden, it's not as cool as it used to be, right? So now we have pharma. I'm so glad that you guys are here. We have endoscopy with great data. And you both, Medtronic and Ethicon, we just met at the Corporate Council, have been very generous about embracing the diversity of therapy. But at the end of the day, Gina, let's just be honest, right? You're a corporation, right? You're for profit as a corporation. Just like my business is of profit, there's nothing wrong with that. My company is for profit. How do you really, when you go back and how do you tell them, do you go say, oh, holy crap, they changed this to other therapy. Now they had pharma there, Eli Lilly was there, and they gave the award for industry for a guy who does endoscopy. How do we digest all that, and how do you guys think of all that? So all of you, we'll start with Gina, because it's easiest for me, and then we'll go around.
That's a big question. Before I answer that question, I'd like to make one comment about Jaime's presentation. One thing that was missing in that was the fact that, yes, the ban came to the market, but we didn't talk about the great things that happened as a result of that, right? How many of you in the audience had patients come to you because of those lap band campaigns, but then you actually could talk them into having a bypass or a sleeve? So it actually raised the bar in the industry on some level, even though it wasn't as effective as some of the other operations. So I want to just comment on that because I think it's really important that we look at all aspects and angles of devices and procedures in this space. When we think about Medtronic, you know, we're diversified in GI, general surgery, bariatric, you know, across the spectrum. We have multiple groups. When we look at what's happening today in bariatric surgery, we have to look at where we're going to be in the future. That's the most important thing. And I believe that we need to work together differently in the society. This society and the ASMBS are run by bariatric surgeons. If we don't include endocrinology, GI physicians, and obesity medicine specialists in the societies, in the federations, it's never going to change to where we can all work together and industry can be supportive and profitable in the space. So the space has to change before we can make decisions about the areas in which we're going to produce product.
Thank you, Gina. Do you agree? From Johnson & Johnson standpoint, because you're also very diverse. Do you agree?
Absolutely. And I would say one of the big learnings, and even with the gastric band at the time, is the learning that we are behind the patient care path, the patient journey, and that goes far beyond the devices. So we need to ensure pre- and post-operative good outcomes, sustainability, and if the patient wins, everyone wins. And that doesn't mean that we have to go with only one solution at all. It is the relationship with the societies, with the IFSO, ASMBS, to understand what is the right therapy that might be even complementary to ensure sustainability and time. If that doesn't happen, it's not good for anyone here. So yes, we do have more competition, but the way we see it is exactly the opposite. I'm pretty sure we're probably not even addressing 1% of the total population that should have a surgery or our obesity metabolic treatment. So there's so much space to go, and there is so much we can still learn to complement and get with the right solution for the patient. So yes, we agree.
Paulina, you had a question about pharma.
Well, it was related to funding of the trials, because this is, of course, something that we need to do. And from a company perspective, would you be willing to finance a study that will most likely end up showing that surgery is superior to the drug?
Oh, yeah.
I'm glad you guys started me with the easy questions. I think some of that research is happening, and industry does support head-to-head studies. The data was just released on a head-to-head study between our product and Novo's product. But if I might politely just take issue with the question, because the question has underneath it a perspective that it is a necessary choice between one or the other.
Oh.
And I'm not sure that that's the case necessary. When we look across the population with obesity, there needs to be a range of therapies available for individuals, that a clinician makes a decision with the patient on what the best approach, given their health status and their health aspirations, are going to be. So from my perspective, and I think from my company's perspective, we are supportive of improved access to every form of evidence-based obesity care.
That is our joint target, definitely. That's clear. It's not a meaning that we're aiming to do that, but sometimes you have to state the hypothesis in that way, and that's why I'm asking that.
Sure. Well, I think there was a wonderful presentation earlier about investigator-initiated research.
Yes.
I think that is a perfect topic for an IIR. Lilly supports IIRs. There's highly rigorous review of protocols, as was mentioned earlier, and I would encourage you and your colleagues submitting one to Eli Lilly and Company.
Brian, I'm actually, a lot of people are texting me questions. It's really too bad this is that late. Brian, what do you see endoscopy in 20, 30, 35? Bariatric endoscopy, that is. Today, the best video that was chosen was robotic ESG. We all agree that the problem with ESG is there's no landmark, there's no nothing, you know. So while we're learning, it's still very inconsistent. In addition, Mohit presented very provocative presentation, and we know he works with you guys. We just spoke about conflict of interest, and he said surgery is extinct. Everything's going to be ESG. We're going to sell it in Walmart, in Walgreens. Everyone gets ESG. So can you comment on this? You're like the star of the show now. What is it that you think is going to happen 2030? Are you going to be like the lab band and ESG is going to go away, or the future is going to be endoscopy?
Yeah, so there's quite a bit in there.
Right.
But let me give a few different thoughts and perspectives. So I would say, first of all, I'm not sure that was how Mohit characterized ESG. I think that's a strong statement for sure. The world of endoscopy is kind of the natural progression of minimally invasive surgery, and we're seeing that in a lot of different ways. So I think we as a company look at endoscopy as the next generation of surgery, endoluminal surgery. And if you don't believe that in the gastrointestinal tract, I would look at a lot of different specialties, whether that's cardiac or neurosurgery or vascular surgery, that kind of thing. So we're a proponent of making things less invasive and doing that through an intraluminal approach in general, including endobariatrics. I think it's a particularly exciting time to be trying to take care of this disease burden of obesity, because we're seeing more tools come to bear than we've ever had. It wasn't so long ago that if a patient presented to their clinician wanting help with obesity. They either had lifestyle modification or surgery. And while surgery is safe and effective and the most effective intervention, a lot of patients haven't opted for surgery. So now to have more options to treat them along their continuum, I think that's a good thing, whether that's pharma, an endoscopic intervention, surgery, or the other things that are coming down. So that's where I'm going. First, I think ESG right now is helping to fill the gap between non-surgical and surgical intervention. Our goal is to continue to build a portfolio that helps to fill that gap, so we won't stop with endoscopic suturing, and that's where we would see the future. We'll see enabling technology that might make suturing better. You saw an example of that in the president's session with the EndoQuest robot. You might see combination therapy, magnets and endoluminal. You're certainly going to see more enabling technology around suturing if we have anything to say about it. So we see that this field is going to continue to grow. We feel it's a nascent field that needs to be managed well. That's education, that's more clinical data, that's not overstating to our patients what this can deliver, and that's making sure that it's delivered within comprehensive care and not just out in some ESG factory.
Thank you so much. I was trying to give a loaded question to create conflict, but you defeated me with your kindness. Camilo wanted to, Claudio, please go ahead.
Well, thank you very much. I think this was very, very, very insightful for me that I work with the government here in Chile. I don't know if you're aware, but now Chile have raised their surgeries from 8,000 cases to nearly 30,000 per year. And we are the country probably that do most bariatric surgery per capita in the world now. So this is very interesting. So I have like two questions. The first one is that 10 years ago or 15 years ago, all the scientific work was done with the universities. For example, Camilo worked at the Católica, there was University of Chile, and those was the made data and works, okay? And now with the rise of this, procedures, there are some centers that have an insane amount of patients who can create their own data. So this is my two questions. Do you think this is a global phenomenon? And if you were more willing now to put money in a private hospital or in a hospital with a university? That's my two questions. Thank you.
Thank you. Anyone wants to take this?
Maybe before that the answer, because I would add to the same question, because I think it's a very, very interesting thing. I've been the president of the Congress dealing with funding and bringing here, and we are missing, I'm not sure if we are missing, but we are missing an important part of industry that is not participating, that tends to go from the side and always dealing with the side. We have like events in parallel of the Congress. I've been dealing with these things, and we try to be as straight as possible with our partners that have really supported us. How do we deal with that? How does industry, your industry, expect us to deal with this? Because if surgery is becoming a baking store where you sell bread, they want to make as much money as possible. And we designed a very interesting model that Claudio said about doing 30,000 cases, but that means that the stress on price is horrible. They are performing hundreds of surgeries. Tijuana, now Santiago is becoming some, Turkey, and you are out of that game. And I'm not sure who's making the numbers, but that's a really big threat. How do you expect we behave on that? Because it's a big threat. And everybody's falling on that. Everybody's falling. How can we continue to support each other? Because we feel that that's important.
So let me, thank you, Camilo. Sorry, I'm cutting you off, but we're going to split this question. So the first one, maybe Gina, do you want to comment on this? The first one would, or any one of, please, would you as industry now have lower threshold to talk to private practice and support their initiative for research? Very, very quickly, because then we're going to touch on medical tourism and having the cheaper alternative. Gina?
Yes, we would support funding in private practice, especially if you have a massive database of patients and fantastic outcomes, and you have the resources to do the work that's necessary to create the information and publish. Absolutely. We don't discriminate. And then for the second part,
Let's hold off on the second, medical tourism. Do you want to have a comment? What are you looking for in private practice to collaborate with? Very, very quickly, please.
We look for, I would say, formal protocols that ensure that they are speaking to any other institution and that they're not going away of what is exactly what, the entire system needs to make that information credible, sustainable, and that would also just deliver good or bad results, whatever it is. But it's gonna indicate in which direction we are. But about the quality of data, the formality of data, and the way how it's treated. And there is, I guess, also opportunities because usually bigger institutions do have the entire structure. I understand smallers do not. So the question is, how can we as an industry also support in bringing those protocols to elevate the quality of information that is being processed?
Thank you. Ahmed,
Just a quick
yes,
comment
please.
about that. I think we're in an era where research is no longer just the domain of the academic institutions, and we have so many more tools to pull on. Real-world evidence. You got a database, you know how to harvest it, you can talk to our data scientists, we're interested. You're a private institution, but you've got research infrastructure in order to run a high-quality clinical trial. That's what's required to get regulatory clearance. We're interested. So it's more about the infrastructure and the capability. It's less about the setting.
So, Ahmed, I'm going to put you on the spot here. I'm taking a picture first with Sasha, just so you know. So I'm going to turn like this, so it looks like I'm important to show my kids, Ahmed, we were in London, and you were on BBC, you're that important, talking about 7 unfortunate cases where 7 British patients who struggle with obesity passed after going to Turkey. I was there, so to spice it up, Camilo, further, I was there at the end of the session, just like now, people are exhausted, and I remember a surgeon raised his hand and said, this is literally, you guys will be interested in this, we should all, I'm quoting, we should all get together, so any patient who goes to Turkey and has a complication, we will refuse to deal with those patients, then the rest of the patient will learn a lesson. So I raised my hand and I said, basically, you're nuts. And medical tourism is a problem because it's $25,000 to have a sleeve in my hospital. It takes me 20 minutes. And $75,000 cash, $75,000 cash to have a sleeve at University of Chicago, which is going to end up being done by a resident or a fellow, so it's nothing special. I remember I talked to Jaime about it, and Jaime and I started our own company, American Bariatric Centers, for low cost, still though, FDA-approved device. So the question to you all, anyone here, what do we do with this? What do we do? There are staplers now that are extremely cheap. I remember Mufi said $1,400 to have a sleeve in India, and then an Egyptian guy said in Egypt $800 because the surgeon actually makes his own staplers. But then you can't blame this because this is a country of almost 1 billion people, and they are very poor. So you can't blame the patient, in my opinion. So what do we do? What do we do with this insanity? And who's responsible? Is it the patient? Is it us? Is it money? Anyone wants to make a comment? Maybe, Ahmed, you start.
Yeah.
How did you get to BBC for this?
Look, the issue, Rami, is ultimately, if you have a situation where there is a demand for something, but there's no supply. So in the UK, we have a problem. We don't have enough bariatric surgeons. We don't have enough hospitals. And essentially, we have very long waiting times for surgery, 2 to 3 years in the NHS. This means that patients who need to have surgery will find other ways of doing it. Private surgery in the UK is expensive, just like it's in the US. So they do the natural choice, which is to find another place where they can go and have the surgery cheaper. My own feeling is if the surgery is being done safely and they get good follow-up and good care, then why not? It's their lives and they want to make it better. And if the country can't provide it, then it's absolutely fine to go abroad as long as they're getting good care.
All right, Senia, you want to say something?
I just want to add about the value of informed consent. I think that's probably what needs to happen, whether it happens in one part of the country, of the world or not. And the same thing goes with actually different treatment options for obesity as well, right? Whether it's surgical or non-surgical. So as clinicians, instead of saying, or as surgeons, we will not take care of that patient who's had a complication because personally, I don't agree with that. We have to take care of the patient. I think we should focus on making sure that the patient is well informed, and if that particular clinic in Turkey or anywhere else in the world is not doing their job, maybe we need to just educate our patients to ask the right questions and be more informed as to what happens after surgery, what can happen, what does long-term post-op care look like, where would you be able to get that so that that weighs in the decision-making and factored in with the cost as well.
All right, anyone? Phil, do you want to say something?
Yeah, just briefly. My biggest concern about the medical tourism is the lack of good pre- and post-operative care. A lot of these patients are getting virtually zero pre-op education, preparation, medical optimization, and that is critical. This is a chronic, progressive disease, and education about their vitamins and about long-term complications. They're not getting that, and they're coming home after their procedure, and if they have complications, where do they go? They never land into a place where the receiving facility is expecting these patients. There's never an attempt to place these patients back in their home environment. And so it's just a recipe for disastrous. We've all seen this, unfortunately. It does put the local physician in an uncomfortable position, but I do agree, we're members of ASMBS. If so, we've agreed that we're going to take care of these patients that need our care.
But we have to remember that American surgeons have their own complications, and they could be elsewhere. Because I take certain employers like United Airlines and Walgreens, they come to me from all the states. You had the Boeing contract in Cleveland Clinic, and these people come from all over the states. So I think migration of the patient is an issue. And, in Tijuana, for example, there used to be, 100,000 Americans, they go to Tijuana. These people cannot pay the money. So then do we look at here, Johnson & Johnson and say, every cartridge is $150, $180. The stapler is another $500. And if you want to throw staple line reinforcement, is more and more and more. So where do we see, what do you think the solution?
I mean, I'm an engineer as a background. We need to compare apple to apples. So here, this is a question that we are comparing a piece of the continuum of care with the entire process. And that's not fair. And that goes to Camilo's question. So somebody's taking care of that post. Maybe nobody's taking care of the pre. So who is the one that really loses is the patient. And we need to integrate. And I truly believe that there is a function of the societies. There must be some regulatory entity just falling in and understanding how that is and inform the patient about that, because they are not being treated equally.
Although a lot of these patients, they go based on TikTok. They don't come see someone like Dr. Kurian, and then she says how much she's going to get, or they decide. We're not seeing these patients. I think it's a very, very big issue. Paulina, as we wind down here, you are in a very socialized country. Do you see a waiting list? What happened with guy or women who are going to have surgery in 14 months? Or your country is kind of a little bit smaller, you don't have that problem?
No, we do have a waiting list, and we do have the medical tourism issue too, so it's exactly the same.
Okay. Any other comments? Anyone?
It's a very, very complex problem, like everybody says, because too many patients are going there just because of the price. That's it. Many of them even have insurance coverage, but the deductible is very high, and it's cheaper to go and have the surgery there. So this is pretty amazing. Second biggest issue is that the informed consent is not given to them. They're reusing, and I've been there, and I can speak clearly of what's happening there. They're reusing staplers through the several cases until the stapler quit working. They're reusing trocars, they're using energy devices. That's how they come up with a cheaper price. They're not disclosing that to the patient. And then they only embracing, like Phil Shower said, the surgical event. So the education that they get is, they all get to an auditorium, they tell them what's gonna happen. If they get in the morning, they get surgery in the afternoon, they get in the afternoon, they get surgery in the morning, and move on. The follow-up that they get is instructions, and that's it. Nobody's gonna come up. Amazingly enough, with all that, I am still intrigued about 50,000 patients, 100,000 patients. We should be seeing tons of infections or tons of complications. We're seeing some problems, but for the volume that is being done there, I am so intrigued why we're not seeing more related to the way that they handle instruments, reusables, and disposables, and everything else. But it is a huge problem. I can tell you, and that not only happens on bariatric surgery, they do cancer treatment as a medical tourism, they do dental work, as you know, plastic surgery, all kind of things. It is a whole business. And Customs and Immigration of the United States gives them a medical line so they can pass quickly. So where is this thing? I mean, I don't understand. I mean, they facilitate it for the patients to go there. And then the government in Mexico protects the medical tourism. Why? Because it's bringing dollars to the local economy.
Thank you, Jaime. Camilo, do you want to? We're gonna wrap up, but before that, for fairness, Camilo, do you want to introduce?
No, I just wanted to introduce Felipe Miller. He's the CEO of Tabali Vineyard. And really, he's going to explain us very quick way before we finish the wines we've had here.
Okay, well, thank you very much. It's a pleasure to be with you today. I was in the dinner of the president the other day in the museum, so I see some faces I've seen before. So thank you, Camilo. And basically, the idea was to have the tasting before the seminar, but I had some issues at my job. So the idea was to show some of the wines that we produce in Chile. We have two wines today. One is a Sauvignon Blanc, which is a lovely wine from the cold desert of Chile, from the Limeri Valley. A lovely, fresh style, crispy, aromatic Sauvignon Blanc that goes fantastic with the seafood we have in Chile and all the gastronomy with fishes and everything. And the second wine is a Carmenere, which probably many of you are curious about it. Some of you knows it, others not. But it's a grape varietal that is quite unique to Chile, not 100%. It was a lost Bordeaux variety that was used in the Bordeaux blends back in the 1820s, 1830s. And on that period of time, there was a pest that arrived from America to Europe. It was a small bug, which is called phylloxera, that ate the roots of the vineyards, of the European vineyards. Not the Americans. American vineyards were resistant to this bug. European weren't. So there was a big devastation and disappearing of the vines in Europe. A couple of decades before, some Chilean entrepreneurs brought vines from Europe and established them in Chile. Cabernet Sauvignon, Merlot, Pinot Noir, Sauvignon Blanc, Chardonnay, etc. So amazingly, the Europeans, when they discovered, the way of fighting this bug, they came down to Chile and brought vines back to Europe. And in that exchange, there was a variety that was lost, and no one else saw it after that, which is Carmenere. In 1994, a French ampelographist, which is the specialty of agronomists, that they, see the different varietals. There are around 5,000 different grape varieties in the world for making wine. Many of them are in Italy. In Chile, at least, we're very franchised, so we're more used to the French varietals. But there are many in Greece, in Georgia, in Eastern Europe. And the guy was walking, advising a company, a winery. He was walking in a Merlot block. And suddenly he said, I see some plants that are different. The shape of the leaf is different. The green color is not the same as, what is happening here? And he went to talk to the guys that work there. When is the bud breaking date of this? Is when the bud starts appearing. When is the picking date? What is the color of the top of the... And he realized that some plants had a white top in the bud, which is Merlot, and the other one was reddish, was a kind of a copper color. He went back to France, he brought some vines and leaves, and he discovered that it was Carmenere. That was 1994. It was a lost Bordeaux variety that was preserved in Chile, but wrongly classified as Chilean Merlot. In 1996, we had the first 100% Carmenere wine bottled and labeled as Carmenere, and that's a new part of the story of the Chilean viticulture and winemaking. So over there, we're going to have glasses of Sauvignon Blanc from the north of Chile, from the coast, and a Carmenere from a lovely place called Peumo, where we have great conditions for that grape to show the best quality possible. So
thank you
that's
so
it.
much.
Thank you very much.
Thank you so much. I wanna thank you all. I know it's way past 6, and there are actually still people here. And I mostly want to. I don't care so much about these people, but mostly I really want to thank you. I hope this will be new trend where we can sit and ask questions. And thank you so much for your support. We couldn't have this without you. Of course, thank you, Camilla, for the millionth time. Ahmed, Paulina, and my very, very good friends. Thank you, and have a wonderful night. Yeah. Let's do it.